What breakthroughs are we excited about?
Yeah, I think, again, more in the space of personalized therapy. We had, of course, first immunotherapy, and now, more and more of these antibody drug conjugates. So I think I'm really looking forward to more of that, and also how we can kind of combine these therapies. As I mentioned before, now we're combining immunotherapy with antibody drug conjugates. We're moving them up even earlier from the metastatic setting to early stage setting. So all of these efforts for our patients to, in the early stage setting, to be cured of their breast cancer, and in the metastatic setting to live longer with very good quality of life. So I think, there's a lot of exciting advancements on the horizon in breast cancer.
The information provided on this podcast for educational purposes only and is no intent, nor should be used as a substitute for medical advice. Consult a licensed qualified medical physician for any issues concerning your health. If you would like to know different strategies to improve your quality of life during your cancer journey, this is the podcast for you. Welcome to Taking Charge of My Cancer podcast, where I'll be interviewing different healthcare professionals, cancer survivors, and I'll be teaching you different resources, tips, and solutions so you can get the best outcomes while dealing with a cancer. So, welcome back to Taking Charge of My Cancer podcast. And my guest today is Dr. Armaghani, and she's a medical oncologist who specializes in breast cancer. Every week, we'll talk about the latest treatments, research, breakthroughs, and the real challenge people face during diagnosis and treatment. My goal is simple: make a cancer science easier to understand and bring honest conversation to the front of care. Dr. Avan Armaghani is a breast medical oncologist at Moffitt Cancer Center in Tampa, Florida, where she treats both women and men with breast cancer. She earned her bachelor's degree in biological and medical science from the University of Florida in 2009, and went and received her Doctor of Medicine from the University of Florida College of Medicine in 2012. She completed her internal medicine residence and hematology oncology fellowship training at Shands Hospital at the University of Florida. She has a strong interest in medical education, mentorship, and physician development. She is a core faculty member for the University of South Florida and the Moffitt Cancer Center Hematology Oncology Fellowship Program, and served as the breast oncology rotation leader. She has participated in numerous leadership initiatives and serves on committees of the local, regional, and national levels. She's an active member of the Hillsborough County Medical Association and the American Society of Clinical Oncology, ASCO, and the American College of Physicians. So, Dr. Armaghani, thank you so much for being here. I really appreciate it.
Yeah, thank you. Thank you for having me, and thank you for that introduction.
Absolutely. So tell me a little bit about breast cancer treatment has evolved significantly. So how will you describe where are we today compared with 10 to 15 years ago?
I think the best word to sum it up is personalized. I think that we have definitely moved from breast cancer being kind of one size fits all to now being personalized to each individual patient, and figuring out exactly the kind of the tumor makeup and any specific mutations and things like that. So we're really able to personalize therapy based on each patient's unique breast cancer.
So what are the main type of breast cancer, and why does subtype matter so much in treatment decisions?
So we categorize breast cancer into three main buckets. The first is hormone receptor positive, or sometimes you'll hear estrogen positive or progesterone positive, but there's hormone receptor positive. There's also HER2 or HER2 positive, and then there's triple negative. So that's really one of the first steps in the diagnosis of breast cancer. Is once you get that pathology report back, your next question really should be, okay, what subtype or what subcategory of breast cancer do I fall into? Because that guides treatment planning.
Okay. A lot of times, if we go back into these categories, patients sometimes come to the clinic and being petrified because they say, oh my God, I have hormone replacement and now I have an estrogen positive type of cancer, I did that to myself. Estrogen is kind of like I'm feeding cancer with estrogen. So if you can clarify how exactly that works, because we really have estrogen everywhere in the body, right? So estrogen is so important for us to just function as a woman. So how can you clarify that for them?
Yeah, I think, this conversation around hormone replacement therapy, it's an ongoing one. And I know that recently there's been some new discussions about the use of hormone replacement therapy and its risk in breast cancer. And I mean, I certainly have that discussion with patients when they feel like, they did something wrong when they took hormone replacement therapy. I think that, we just kind of have to focus on what we're kind of addressing now with the breast cancer. Now, of course, moving forward in any patient with a history of breast cancer, we don't recommend any hormone replacement therapy moving forward. But the risk of hormone replacement therapy in breast cancer, it's a controversial topic. It's an ongoing topic and discussion that I would recommend, having that discussion with whether it's your GYN or your primary physician about that.
Would you explain the difference between hormone receptor positive, HER2 positive, and triple negative breast cancer in simple terms?
Yeah, so when you look at the pathology report from your biopsy, you'll see the estrogen receptor, progesterone receptor, and HER2. So those are the three that we're looking at on the cancer cells, the presence or absence of. So if it's hormone receptor positive, the estrogen receptor and or progesterone receptor will be present or positive, and then the HER2 will also be positive. But triple negative, all three are negative, so that's why they call it triple negative.
Okay, so how is breast cancer staged and how does the staging guide treatment?
The three components of staging of breast cancer is of the breast cancer, any lymph nodes involved, and if there are lymph nodes involved, exactly where their location is. And then the final one is if there's any distant spread of the breast cancer to other organs, other parts of the body. So we use those three pieces of information to come up with the stage of the breast cancer.
Okay. And how about genomic testing? How does it change the way that you recommend chemotherapy? And what exactly genomic testing means?
Yeah, so I think about genomic testing. So there's kind of two components to it. First is routine, what we call genetic testing, which is like you may be familiar with BRCA1 and 2, which are gene mutations that can increase risk of breast cancer and other cancers as well. But now we have what we call expanded panel testing. So it's not only testing BRCA1 and 2, but it's also testing other genes that also could have implications for higher risk of breast cancer. So that's one type of testing, and it's really testing you yourself if you have any mutations. The other type of testing often we call next generation sequencing. And this is testing of the cancer cells, the genetics of the mutation status of the cancer cells. And that's important because that can actually evolve over time. And that is particularly important in patients with stage 4 metastatic breast cancer because it goes back to that personalized therapy. If I can identify a mutation in the cancer cells with this next generation sequencing testing, I can potentially have a certain drug or medication that targets that mutation. So it really helps us in treatment planning.
So when is chemotherapy necessarily? So, you have patients who come and they like, oh, I just have breast surgery, and are you going to have chemo now? So a little bit a better way to explain to them when is chemotherapy necessarily and it is okay safely to be avoided.
Most triple negative breast cancers, all triple negative breast cancers and HER2 positive breast cancers do require some sort of chemotherapy based treatment. Estrogen positive or hormone receptor positive breast cancers may not necessarily need chemo. Now, this in the hormone receptor positive breast cancers, and again, I'm talking about early stage, not metastatic, but in the early stage, we really take into, of course, the consideration, the stage of the breast cancer, the age of the patient, and other characteristics of the cancer to determine if they need chemo before surgery. Now, if those patients with hormone-positive breast cancer do surgery first, depending on the surgery results, we may be able to send a test called an oncotype. And the oncotype is a genomic assay where we take the breast cancer tissue, we send it off to a lab, and it does this whole analysis on the cancer, and it gives us a report back. And the oncotype really gives us an idea of the biology of the breast cancer. And based on a lot of long-standing data, we use the oncotype report to determine how much or if any benefit there will be for chemo after surgery. But keep in mind, oncotype is only used for hormone-positive, HER2-negative breast cancers.
Okay. How about K67? How that works?
Ki-67 is important. I mean, it is reported out in our pathology reports and is another indicator of how aggressive or non-aggressive the breast cancer is. Ki-67 has over time has been increasingly more important and also plays a key role in some of our treatment decisions as well, particularly in the post-surgery setting for hormone-positive breast cancers. There's some implications for treatment. So it has become more of a very useful piece of information in our pathology report.
Great. How about target therapies, and how are they different from traditional chemotherapy?
Yeah, our treatment in breast cancer has definitely shifted more towards targeted therapies. So I think about targeted therapies. I think of Herceptin and Perjeta, for example, as targeted therapies and not routine chemo because they are targeting specifically the HER2 protein. Now, other targeted therapies, for example, immunotherapy. So immunotherapy, we're using more and more in breast cancer, and also newer drugs, what we call antibody drug conjugates. These are targeting specific markers on the cancer cells. So they target a specific marker and then they deliver chemo directly into the cell. So rather than chemo, run-of-the-mill chemo, which is more of a shotgun approach, these antibody drug conjugates are targeted specifically for cancer cells. And so we found that they're a lot more effective, of course, compared to chemotherapy. Of course, side effects are different from one drug to the other, but we are moving more and more towards targeted type treatments in breast cancer.
Immunotherapy has been a big topic. So how does this fit in breast cancer treatment?
So we're using immunotherapy in mostly triple negative breast cancer right now, both in the early stage and in the metastatic setting. And what's very exciting is most recently, we're now starting to combine immunotherapy with antibody drug conjugates in the metastatic setting, and compared to just, and it's much more effective compared to just chemotherapy. So immunotherapy in breast cancer was a huge milestone in just treatment advancements.
Yes, I have seen that. I remember I used to have a patient a while back, and she actually was really good about researching different institutions, and she was triple negative. And so she came to us here at UF. And at that point, I guess the medical oncologist that she saw, we were not really doing a lot of the neoadjuvant chemo plus the immunotherapy at that point. But she came to you guys for a second opinion, and you were offering that. And she was like, I kind of want to have my treatments here, but I want to have immunotherapy. So we couldn't really offer it because we were not doing it here at that point. And then she ended up doing the neoadjuvant chemo with you guys, and then surgery and everything else here. What are the common side effects of endocrine therapy, and how do you help these patients to manage them? Or if you can explain a little bit what is endocrine therapy.
So endocrine therapy or hormone blocking therapy, estrogen blockers. So these are all, different terms that are used interchangeably, but these are medications, they're pills that are we use it for patients, of course, with history of hormone positive, HER2 negative breast cancer to essentially prevent recurrence, prevent the cancer from coming back. And I tell my patients, this is really the long game. Because these medications are given anywhere between 5 to 10 years. Now, admittedly, these medications Their side effects are not fun. I think majority of patients have side effects that are manageable. However, common ones are hot flashes, joint aches or stiffness, can sometimes impact bone density, causing osteopenia or even osteoporosis, trouble sleeping or hair thinning, mood changes. And oftentimes these side effects can be more intense in the beginning and will kind of level off over time. But I certainly have patients in kind of the one end of the spectrum where the side effects are just very hard to manage. And this is a quality of life issue. There are two main groups of hormone blockers. There's tamoxifen, and then there's another category called aromatase inhibitors.
And would you explain to us a little bit more about what's the difference between one versus the other?
Tamoxifen, what it does is it's going to block the estrogen receptor. So what I think of it is it's taking up that parking space so that the estrogen can't go and bind to that receptor. Tamoxifen we can use in women who are both premenopausal and postmenopausal, and it's a pill that you take once a day. Aromatase inhibitors, what they do is they're blocking the production or conversion of estrogen in your body. So it's basically lowering that systemic level of estrogen. Now, aromatase inhibitors are used in postmenopausal patients, and there are 3 of them in the category. They include exemestane, anastrozole, and letrozole.
So if tamoxifen can be given in pre and postmenopausal patients, what's the advantage? Because we know that it's so much better to have a estrogen receptor, right? Versus just depleting systemically estrogen in the body. So postmenopausal women already are having issues with postmenopausal symptoms to beginning with. So why not offering tamoxifen in that postmenopausal setting?
It's a great question. There's a lot of data that has compared the two. In particular, in postmenopausal patients, we have seen an advantage of aromatase inhibitors over tamoxifen in postmenopausal patients in terms of risk reduction of recurrence. So that's why we choose aromatase inhibitors as our first go-to in postmenopausal women. However, that's not to say that tamoxifen is not effective. So with that being said, for example, if I have a patient and they've gone through all 3 aromatase inhibitors, none of them are, they're tolerating well, then our fallback will be tamoxifen.
Okay. I have these questions every single day. I see a good amount of breast cancer patients, and I want to say 99.9% complain about side effects from these medications. And a lot of them ask me, should I continue taking that or not? And a lot of them actually are having a horrible quality of life, and they're really taking it because they're so afraid for the recurrence. So how much really these medications help with that recurrence, right? That is worth it to sacrifice that quality life over that.
I think it really depends on the breast cancer, the stage of the breast cancer. Of course, if you're higher risk, you're going to have a much greater reduction in recurrence because we've seen that hormone blockers can reduce risk of recurrence by upwards of 50%. So when your recurrence risk is already starting high, then your kind of delta and drop in recurrence is going to be much higher than if someone was starting off with a recurrence risk of, let's say, 5%, because they were such early stage, then you're only getting a 2.5% drop. So these are the conversations that I have with patients. Of course, we would love for every one of our patients to be on treatment for the recommended 5 to 10 years, but quality of life is our number one priority. So these are the discussions that we have in clinic. We talk about, well, okay, this is your risk of recurrence with and without the hormone blocker. And ultimately it is the patient's decision, but we have to respect that, if the side effects are really intolerable, then there are times where we just have to say we have to stop and we monitor closely. So, that's kind of how we work through these things.
Okay. And talking about that, because the symptoms, so we know more now that it is a lot of issues with genitourinary menopause syndrome, which is, a lot of vaginal dryness, UTIs, pain with intercourse, etc. So we know how that is really becoming such a big issue. when we have the hormone blockers. So it's something that is being used called vaginal estrogen. So what is your opinion with patients being on the tamoxifen or the IAs and vaginal estrogen?
We know that it's safe. It's safe for use. And so that is something that I commonly will prescribe to my patients. Certainly, we first recommend non-hormone based type of remedies, but certainly if those are not effective, then typically what I recommend, it's a vaginal insert. It's called Vagifem that you can, that I can prescribe for my patients. And it typically is successful in providing relief. So vaginal estrogens are safe for us to use in patients with a history of breast cancer.
Okay, great. That's such a relief. It's such a big controversy. I come across some medical oncologists who say, well, no, really, we shouldn't be using that. With the tamoxifen, they feel okay, but with the AIs, they don't. And I'm not quite understanding why is that.
Yeah, so there is discussion about a vaginal DHEA. It's called prasterone. And the issue with this medication that I actually have recently run into is cost. So I've had patients come back and say that it's a high cost for them and they're having issues with insurance covering it. But kind of the theory behind it. So in patients with tamoxifen, it blocks the estrogen receptor. So small amounts of estrogen that are absorbed from any type of vaginal estrogen are not as concerning because we're not concerned that that could go and bind to an estrogen receptor if the tamoxifen is already blocking that receptor. Now, the difference is aromatase inhibitors, they're keeping the systemic estrogen levels low, right, by blocking that conversion to estrogen. So theoretically, even small increases in circulating estrogen, if you're using a vaginal estrogen, could maybe counteract AI therapy or aromatase inhibitor therapy. So again, this is all kind of this theoretical thought, and that's why these vaginal DHEAs, it's converted locally in the vaginal tissue to estrogen and other androgen metabolites. So there's very minimal systemic estrogen increase. Serum estradiol levels remain low. So that's why we think that it's safer to use that in patients with who are on aromatase inhibitors. But again, we're facing these issues with costs. If we have to, we go to a vaginal estrogen based therapy.
Great. I'm so relieved that that's more and more out there because patients
Yeah,
locked out. It's like, we try to prevent a breast cancer recurrence, but at the same time, if you end up with a UTI, was the first thing that
right.
happened to you is your changes on mental status, your fall risk. Now you're breaking a hip because you are
Exactly.
supinial osteoporosis. So it's like, wow, it's a lot of things that can actually be very helpful to
Yeah.
in the beginning. What breakthroughs in breast cancer research are you most excited about? At what questions should, what
I
life,
think
what breakthroughs are we excited about?
Yeah, I think again, more in the space of personalized therapy. We had, of course, first immunotherapy, and now, more and more of these antibody drug conjugates. So I think I'm really looking forward to more of that, and also how we can kind of combine these therapies. As I mentioned before, now we're combining immunotherapy with antibody drug conjugates. We're moving them up even earlier from the metastatic setting to early stage setting. So all of these efforts for our patients to, in the early stage setting, to be cured of their breast cancer, and in the metastatic setting to live longer with very good quality of life. So I think there's a lot of exciting advancements on the horizon in breast cancer.
That's excellent. So what would be your advice for patients who they are newly diagnosed with breast cancer and they step in onto a medical oncologist appointment like yourself? What will be the main questions you think they should ask to their medical oncologist?
I think it's important, of course, to just understand, what category or what bucket that your breast cancer falls into. So we go back to what is the stage of my breast cancer? What are the receptors? Is it hormone positive, HER2 positive, or triple negative, or whatnot? So that's kind of the very That's important first step. And then I think just getting an understanding of course, the proposed treatment. Why are we recommending this treatment? And then understanding the side effects of treatment is very important. And then I think another really important question to ask is, are there any clinical trials that are available for me? I think sometimes we think about clinical trials as, kind of the last thing we think about, or there's no other options available, but that's changed. And oftentimes we're thinking about clinical trials as kind of our first treatment plan. So definitely ask about trials.
Okay. And what gives you hope when you think about the future of breast cancer care?
Well, I mean, I think, just all of these scientific advancements that are on the horizon. And, I think that it's just seeing how things have changed since when I finished my fellowship until now. I think that there is just so many great things that have happened in breast cancer and that are coming. And, just being able to see my patients in clinic that are thriving and doing so well. I mean, for example, my metastatic breast cancer patients, they're living much longer, and because of all of these amazing advancements in therapies. So that's the best part of my day to day, is just being able to see my patients thriving and doing so well because of these scientific advancements.
That's great. What are your thoughts about the role of physical therapy in the middle of, patients who are receiving chemotherapy?
I love physical therapy. I'm a huge fan. And especially, in our patients who, like after surgery, I encourage them to see our physical therapy team because they just do so well. Our physical therapists, they work closely with our patients to help them with improving range of motion after surgery. And I think that also kind of boosts the confidence of the patient as well, because, now they're getting their life back, right? Like they're getting their range of motion back. They're going back to being active and doing all the things that they did before all of this. It's just, it makes a huge difference.
Have you usually recommend physical therapy, like in your neoadjuvant type of situation when you get patients? I'm going to clarify for the audience who doesn't know what neoadjuvant means. That means like you get chemotherapy before surgery. Have you seen some good outcomes with patients exercising in a good high interval training or doing a combination of cardio and strength while they're going through chemotherapy?
Oh, yeah. I definitely think that patients who are active while receiving chemo do a lot better and they tolerate treatment better. Now, of course, their activity might have to be adjusted a little bit, just depending on how they're feeling day to day. But I always encourage patients to be as active as they can while on treatment, because I do think they just fare better.
Okay. What are your thoughts about that? Just how curious to me, when you go and see, I don't know, I haven't been at Moffit, but the other clinics where I have seen chemotherapy infusions happening, it's very like, you sit in this chair for 4 hours or longer. Have you ever thought about doing some more dynamic, like, some of those little small bikes that like you see on the commercials that people sit on a chair and do a little bike? Have you ever thought about like, how can we get these patients moving a little bit while they get in infusions? Is that a good opportunity for that?
I think that's a great idea, because you think about it and you're sitting in the chair, and some of our regimens are like 6 hours long. So I think that's a great idea. Just get them up and moving, and even just like taking a lap around the floor. And no, I think that can only be of benefit in my opinion for the patient. Yeah.
Right. I just didn't know if that was something that certain medications that patients needed to be careful with, or in the beginning of the chemotherapy infusion. Because sometimes I tell that to my patients, and sometimes they say, well, they don't want me to get up and move around much. And I'm like, why is that? Right. So,
Yeah, I mean, I don't see, I don't know if it, of course there could be certain, like, things to keep an eye out for, but, of course we think about infusion reactions and things like that. The patients are being monitored very closely. If they want to take a few laps around on the floor, for example, or even if they're in their infusion bay and they're doing things, but they're monitored pretty closely. So I think that being active, I think that's a great idea during treatment.
Okay, great. I'm going to try to see we can convince our medical oncology department how let's get out
Yeah.
on grant and get some little bikes for the infusion center. That would be really
Yeah,
yeah.
I think so.
We do tend to do this with patients. I think we talked in the past a little bit about it, where we actually are seeing patients right 45 minutes before their infusions, and we're doing a high interval training with them with the strength and cardio right before they go upstairs. It was a research we did. That was before COVID that we're doing in mice where they were doing aerobic activity like mice on treadmills, and they noticed that the tumor environment, because you increase in oxygenation to the tumor, they have a much better outcomes with radiation and chemotherapy. So I was like, oh my God, we got to start doing this in humans. And we were planning to do a trial with that, but then COVID showed up and we never get around it. But I know has been some other institutions that have been doing some of that in humans. So we start to adapt that. And I cannot tell you if we are increasing the efficacy of no of the chemo radiation, but I know side effects are so much less with the patients who are doing this. They
Yeah.
really like neuropathy and cancer-related fatigue, nausea, all that is so much better. That it really has been, so we call it our chemo protocol. So we really try to see everyone if it's possible prior to chemo. And again, we don't have to see them weekly, but at least get them into this is the program you got to do and continue working on that throughout as much as they can, and has been really great outcomes.
No, I love that. And I think it's so good for the patients. Yeah.
What are your thoughts on fasting prior to chemo?
Yeah, there is there's studies about fasting prior to chemo. I get that question quite a bit from patients. I'm not opposed to it, but I do, in my opinion, I recommend not fasting just because I feel like, with chemo and nausea and things like that, I think it's best to just kind of have something in your stomach, especially, before you get chemo. I think that just kind of helps overall. But I'm not opposed if patients did want to do fasting. But in my opinion, I think it's best just to kind of, keep your diet pretty steady.
Okay, perfect. And where can people find you?
Email, LinkedIn as well. I am on LinkedIn. So yeah, I'm happy to answer any questions or if anything comes up.
Perfect. And I will put that on the show notes. So Dr. Armaghani, thank you so much for being here with me today. That has been a great education for the audience. I'll appreciate it.
Thank you. Thank you so much for having me. This was great.
Awesome. You take care and have a great weekend.
Thank you.
Bye. Thank you so much for listening to the latest episode of Taking Charge of My Cancer podcast. If you have not already, feel free to share this with more people so they can benefit from this information. If you would like to connect with me, see the information on the podcast description. See you later.